Professor Ashok. This program would have been quite interesting and extended also. So my request to Margoob sir to felicitate Dr. Abdul Majid Ganai for excellent comparing and coordinating this program.
This is a great pleasure. You can say also a realization of a dream that we all who are here as organizations, as institutions, as individuals who have been doing our bit in our own kind of way to see that the people who need us get some respite. So coming together here today is a great privilege also, but at the same time a great responsibility also. For the simple reason that credible and independent studies have revealed that people in distress are not a minuscule, but almost half of our population is in distress. That has been established through studies. Then the studies actually, again, a collaborative kind of an effort. MSF, IMHANS, together conducted a study again in the community which found that hardly 10% of people are getting professional help. 90% are unattended. So the responsibility is that, see, everybody, every organization has been doing a commendable job. But initially there was a gap in 90s. We had some so-called NGOs which were local only. Dr. Arshad will recall some of the national organizations would come for a day or two. Rest of the things were because lot of disturbances and whatnot had started, and it is said that trauma also becomes an industry, and we saw it in our own way here also this becoming an industry. But the role of credible organizations, they work as an, you can say, antivirus. MSF didn't come to scale just. Actually, initially I just recall the first interaction was that actually the Kashmir Health Society, they were working on tobacco. Dr. Lajmal Sahib was there, Ali Muhammad Mir Sahib was there. So they just thought that yes, because we would be talking, I would be telling people that we don't have anything in the districts, or we would be the government officials, we would tell them collectively, we will be pleading that district mental health program, India has this is not getting implemented, something needs to be done, this would be always a repetition of that, but obviously the gap was so huge, this needs to be filled. Then Dr. Alagman Sahib said that in one of the meetings, why don't we call Medicine Sans Frontiers also to talk about things. So we had a meeting. After that meeting, the first session was on trauma that was held in medical college. That trauma kind of, is published also. So this was a brainstorming thing. And when they realized, this Nobel Prize winning organization realized that yes, this is an area which we should prioritize. They prioritized, and then they started. We had a symbiotic kind of a relationship. We didn't have clinical psychologists those days. We told them that, okay, this has to be a symbiotic relationship in this sense that we'll be referring you patients, you be with us as our partners and guests in that gutted hospital, but at the same time, you will have to extend because your clinical psychologists come who are experienced the drama only. They would be, and Dr. Zad Saab is here, he would recall days when we would have regular kind of sessions, and that extension would be from MSF. Similarly, other organizations actually have done a commendable job, but we need to come together. We say that independently, howsoever sincere and with full dedication you might do, this is only an island sort of thing, activities, but this is an area which is like an epidemic here. But unfortunately, this is not projected the way it is. With the result that in the community, silent sufferers are there, who if we join hands, the institutions join, that the powers that matter and institutions, mental health professionals, NGOs, civil society members, and at the grassroots level, today we are actually just here for the same. So we see that these representations, what represents actually our experiences in the community as such, are so rich to develop actually intervention protocols, services which are relevant, transformational for mental health in Kashmir will happen after this meeting.
Dr. Suhail Maqbool, who is son of Professor Mir Mohammed Maqbool, the founder of VMS. He is an ACE ENT clinician. He is the backbone of this program. He has been supporting this venture. There are other people who have contributed to this event. Dr. Majid is here, Majid Shafi, Dr. Imtiaz Mansoor is here, a very senior psychiatrist, and Bashir Saab is here, who is director, and there are people from IMHAN, so I can see Dr. Deeba, Dr. Bushra, and I have many colleagues from my department. I can see Masood, Ajaz, Nazia, and Dr. Guzar, senior assistant as well, and assistant professor psychiatric nursing, Dr. Nuzar. So if I miss somebody, I'm sorry, but last, which I cannot actually miss, is Professor Mushtaq Margoob, the architect of this program, and I think we'll have a very good inauguration followed by the scientific sessions. Dr. Arshad is here. I'm sorry, I forgot to acknowledge you. Dr. Arshad from MSF. Have a long session with him along with the guest you are carrying along with. So with these remarks, I would like to call upon Dr. Suhail Maqbool to the podium to say a few words before we move forward.
I've been given the honor to speak a few lines. It was supposed to be, this gathering was supposed to be addressed by my father. Unfortunately, he's not doing so well today, so I had to fill in last night. Professor Margoob Sahab, I informed him that Dad is not well. So he entrusted me with this task of speaking, so I'm not really well prepared for this, and I don't know if I'm going to do any justice. So just starting all over again, I welcome all of you here. You will not find the gentleman's name. You will not find his name on the main board that this has been started by him. You will not find his name on even on an anywhere. You will not find his photograph anywhere. This is something he would detest. He would not like that, because I think the only reason there have been efforts by so many people to do similar things, to set up things for people to do something, but there has been an element of people promoting themselves, their own personalities in that. This is what is different about him, and I'm sorry, coming from a son, this sounds very subjective, but this is true. Even if he has never sought to promote that I did this. He never uses the word I. Never. It's always been we, and it's always been he looks down and to the people he wants to serve. And whenever anything crisis happens, he just looks up. You can ask anybody. He doesn't look laterally. He doesn't blame people. He looks up and asks his Lord for help. And that's it. And God has been very kind to him. He has had very supporting people. He has had excellent people around him. The gentlemen sitting here, all of them, they have contributed in no mean way.
Honestly, this is my third visit to Voluntary Medical Trust, and I always keep on saying, coming here is always feeling very small. Actually, I meet the people here who have understood the life in its real essence. A person like Maqbool Sahab, Professor Maqbool, who started this place, a person like Honorary Secretary of this place, their whole team, who are doing a selfless work without any media glare, without any exhibitionism. That's something that's very, very motivating for me. And I have been very unlucky that I couldn't be the student of Professor Mushtaq Margoob, sir, because the time we left the medical college, sir joined after that. And trust me, there is no program in our, I would say, SKIMS Medical College, Bemina, or JBC, where Majid does not describe him as his great motivator, as his great teacher, and that's how I came to know more and more about Mushtaq, sir. It's through Majid that we get to listen to these things time and again. And today, one of the most wonderful things I came to know about is not only being the guide, the teacher. I think he is really born to be the greatest psychiatrist, Mushtaq Sahab, because he was given the rubble, he converted it into a meaningful institution. a burnt out hospital. What he rightly said was that time once we were interns there, we would send shiver through our spine to see the fate of those patients there, somewhere chained, somewhere being just treated with medicine. And it was like a simple Pagalkhana, what Sir really described it. So it was horrifying. It would distract many of us from psychiatry rather than opting for psychiatry. It was very, very horrifying. And I don't know how Mushtaq Saab did all this, how much pain, how much effort, how much against all odds he must have worked to make it possible. And why I labeled him as the best psychiatrist, not only because of his work, because he has laid down the saplings in the form of these three professors, Professor Arshad, Zaid, and Majid, who are really doing a wonderful work, wonderful job. Because I have seen them going beyond their office schedules, going to media, going to press, going to conferences like this, spreading the message. And the biggest taboo still, what continues to be in our society, is no parent is ready to accept that my child has a problem of citrus, my child is suffering from psychosis. If any of the relatives suggest to them that why don't you consult a psychiatrist, probably that relative is treated as the biggest enemy of that family, and as soon as he would leave, the parents will start cursing him. What rubbish he is talking, he is considering our child bad Hindu. So this is one of the miseries. Recently there was a conference in our SKIMS Medical College hosted by Dr. Majid. It was on child psychiatry. All the worthy parents were sitting there. And I told them very frankly and bluntly, trust me, the present day children don't need a psychiatric treatment. It is the present day parents who actually need a psychiatric treatment. Because we have become their demigods. We want to control their actions. We don't let their neurons breathe. ये करो, वो करो, डॉक्टर बनना है, इंजीनियर बनना है, भाई की तरफ देखो, he did so well, you are not performing. Every time they have to listen to this crap. Because why? One of the biggest reasons is mothers are working, they are stressed, come back home stressed, want to finish the household chores. We as males are male chauvinists, don't help them, don't support them. We leave everything to the wife. And the ultimate result of the ultimate wrath is to be faced by the children once the mother starts rebuking them on each and every point. Father starts defending, and ultimately what we make out of them are the simple, fragile chocolate boys and chocolate girls who cannot face any citrus of life. Trust me, for us it was important in the childhood to play in the Malla, to play in the streets, to play in the gully, and get an exposure to every sort of good, bad thing, and then ultimately decide what's good and bad. આજકાલ what we are focused on, no baby, don't play with him, he's a bad boy, he's a good boy, and ultimately what happens, the baby is sitting in his room, becoming a drug abuser, becoming a frustrated soul, becoming a lost soul. We fail to acknowledge it. A person sitting by your side, you might feel in the heart of hearts he's probably one of the luckiest persons, but at times the pain through which he is going, probably nobody understands it. For a psychiatric patient, I would say an Urdu verse like, "Ek ajab hi jang hai mujh mein, ek ajab hi jang hai mujh mein, koi mujhse hi tang hai mujh mein." He's in so much of conflict, it's very, very difficult to understand him. It's very, very painful to understand him. But the initiatives like this, SAWAB and other things, taken up by Professor Mushtaq, Voluntary Medicare Trust, I am really highly appreciative of these things. We need to have the community outreach. So the solutions for these things are, I'm sure they are the biggest experts of this field. They must have framed a draft plan. They must have framed the ways how to go ahead. They must have drafted the scientific ways to prepare the questionnaires or other things by which they can reach the maximum population. They must have their plans in mind how to approach media, how to approach social cells and other things. But as a principal of one medical college, who's luckily the neighbor of this beautiful trust, I can promise you, sir, if you need any support from us, like a nodal center for such thing, we'll always provide the space, the support from us, the volunteers from us, the nursing staff from us. We're always ready to give it. Because I know 4 people, 10 people, or 10 psychiatrists, they cannot carry on this job. It's a huge task. And the biggest problem which we are facing in our society is that number of psychiatrists is still very less. If we go as per the WHO standards or any other standards of the European world, the number of psychiatrists per 1,000, I would say, per lakh population is still negligible. What Ashok said, that he was giving a lecture for 10 minutes, he said in these 10 minutes, I don't know how many messages of distress calls I must have got. Because these patients, they don't have at times, they can call you at 12 in the night, they can call you at 4 in the morning, because they need a listening ear. That's the most important thing. What Sir rightly said, it's not the medicine always, it's not the other things always, but once you really go close, they just need a listening ear. They need some patient hearing, they need some compassion from us, and they need some love from us. Because physical wounds are the wounds which once shown to anybody can create a feeling of sympathy in him. But mental wounds, hidden and buried in those billions of neurons, probably can be seen by none other than a wonderful psychiatrist. Thank you so much. You will be always there. Thank you so much. And I will take you.
I did my internship here in Srinagar. I was born here. I grew up here in the Habakadal area, and but I went to do medicine in Amritsar and came back. Actually, I was telling Mushtaq, I left Amritsar the day after the exam was finished. I even left my bed and everything else there, and I was planning this time to go back and maybe look at what's happening to that city. But anyway, I left India when I was about 23 years old, and I did my psychiatry training in England. But before that, I had spent a year in a psychiatric hospital in Jammu. I had no intention of doing psychiatry. I was going to be a surgeon like my brother. But then that 1 year, and some of you may find it very strange, at the time I was very much into Russian literature. I was reading a lot of Dostoevsky. And then I started talking to patients, and I thought, this is a fascinating world that you can actually get so intimate with somebody and listen to their experiences. Some of them were very bizarre to me at the time. And then I thought there is a possibility that you can actually change it as well. So that was my introduction to psychiatry. Then I went to England, got trained, spent 3 years there, and then went to Canada, and I've been there ever since for the last close to 50 years now. I think when we talk about models of community mental health, there's one thing that, there are a couple of things. I'm just going to make very quick remarks. Models, are adaptable, but you cannot copy models. You cannot say this model worked in this place, so we'll just take it and copy and put it in this place. Because the social, economic, cultural context is very different, even across so-called low-middle income countries. The culture makes a big influence in addition to, of course, the economics. However, you can adapt models according to your context. So that's one comment I want to make. But there may be some basic principles that need to be applied to all models. And those principles are, a model has to have a humane approach to mental health care. It has to be compassionate, practical, so that it actually reaches people, it has to be well resourced, and that always is limited, and it has to give enough credibility for cultural beliefs and for culturally based attribution to mental illness. I think in Kashmir, like in many places, external events have such an impact and they're out of our control. So the best we can do is prepare ourselves with the armor of at least protecting the most vulnerable, even if we cannot solve all of their problems. We're also living in a very, very, at least in my lifetime, I'm 75 years old, we're living in the most terrible times. People who normally would look up to, the leaders, in my opinion, have become simply just destructive. And we have to protect our human life and our values. I think it was unimaginable what we're seeing now. When we're witnessing helpless, feeling helpless, unable to stop it. That's true, you know. Mental illness may just be one of the expressions of what is being done to people. However, places like SAWAB, you know, and the other projects that you're running here and that people are running in other places brings hope. Just to paraphrase Hannah Arendt, who I highly respect as a philosopher, as a whatever you want to call her, you know, as an anti-fascist humanist, she said once that hope is great, but it's of little use when you don't accompany it by action. You have to have action to put hope to serve people. And I think actually doing something is what makes hope useful. You cannot give people hope in words. It doesn't mean anything. You have to actually provide them something. And these kind of projects are an example. And lastly, as you heard, I retired 4 years ago. I mean, I still do little things like, you know, with Mushtaq, I do some work with, again, it's sort of just out of interest with Ethiopia. But otherwise, all I can do now is watch from a distance and admire of what is happening, and I'm so happy to see that 12 years later, there is still some activity going on here. The rest of the time, I'm actually spending writing fiction. So, thank you very much.
The better way probably is to have institutional psychiatry, build it to the level that you have credible mental health manpower produced, and they will seep into the community, and mental health will become available, accessible, as is the general health. You know, as is the health for liver, as is the health for heart, the health for brain will become available at any place. So most of my work started in building an institute of all of us together in building an institute of mental health. And in 2016, we were producing as many as 14 PGs. We were actually able to put almost psychiatrists in almost all the districts. And then came a shocker. We did a survey epidemiological survey, and we found out that in spite of actually now psychiatrists being available in districts, psychiatrists being almost in all, the people who actually are accessing care was dismal 10%, 7 to 10% somewhere. And more importantly, what was happening is that in payer surveys we have found that even though mental health care access might have been less, but people will access cultural care systems, including the spiritual care. We found that that was also declining. So people were actually not accessing that kind of care. In fact, I remember we would lead that 7 patients at the time of survey were to be evacuated. The survey was to be stopped because they were actually contemplating self-harm at that point of time. 7 times it happened during the survey period that the vehicle in which they went was used, the survey was stopped and the person was got to the hospital for. And with that kind of way, so now we have districts which have psychiatrists, we have medical colleges which have psychiatrists, but still the psychosocial programs have their, there's a place for psychosocial programs still to be done in a way that probably SAWAB is doing. We also had Health Foundation. I said we also had an Gap program here, wherein probably, should I say, few students went for training. They also did one autism workshop here. See, they also have had a program with the activity of Health Society, in they had trained doctors in the periphery. Post that, as I rightly said, but even though we have such a rich history of psychosocial programs, people in mental health might understand, but the responses to the community have not been, we do not have many responses from the community, exception probably from SAWAB, that where from our own community, we are actually having a model of psychosocial program which is still running, which started probably in 2013, sir? 13, and it is running. But it's just not possible for one psychosocial program to make mental health available, accessible, and acceptable to the people. I think we probably will need many such programs or other models to make mental health available, accessible, and acceptable. Many times when we were students, we were registrars, we will always think that there's an epidemic of mental health problems. This will be because the kind of overwhelmed we were with the problems.
You all probably know MSF, who we are. We are a really need-based organization who is looking for the need in the population in this time, in this moment for the Kashmiri population. And that is always our focus. We are also data-based, which means that we always be on ground to see what is actually happening, and from that we have our own data. This is always how we work well around. If we start looking into our history, I'm not sure if this is now visible, so let me read. But we started 2001. We started already 2001 as a mental health project. We worked, as always, already then in collaboration with what is now IMHANS. Saying that, we will still have counseling. We are not saying that we withdraw ourselves from the counseling, it's still needed. But our counselors will now be in the communities, on the ground, walking together with the community members and try to understand how can we support in the communities with the mild, moderate distress people with that condition, instead of waiting for them to be severe and catch them in the hospital.
It gives me immense pleasure to join SAWAB and VMS function dedicated to mental health awareness. So I'd like to share something for 1 or 2 minutes. Mental health is an integral part of overall well-being. This program started in 1982, but it was only implemented in 90s in all over India at district levels. Yet often it is not in implementation, it was not so because of some overall deficiencies like awareness, stigma attached to it, and lack of manpower and resources. The Health Service Department is committed to strengthen this program overall in all the districts, especially we started from district Pulwama, and we have a full-fledged unit there. And in Kashmir, we focuses on community-based awareness, early identification and accessible healthcare services and treatment facilities. I deeply appreciate the efforts of SAWAB, and I'm complimenting the VMS on these initiatives through outreach, advocacy and support for need in collaboration between government bodies and civil society. Together we can create a compassionate environment where mental health is given equal importance as physical health. I have seen so many colleagues of mine who, even as now, they don't go to doctors, psychiatrists. They say, no, we won't go there. We don't have such problems. It's just something like that. We are having BP or something. It's nothing to do with anxiety. They don't take it as a mental health issue because they think if we go to a psychiatrist, we'll be labeled like, oh my God, he's mad or he's something, he's not well. I can still, you are taking such initiatives to get this program to community. I am very thankful to you, and with my full heart and from my department, I am thankful for you for this awareness campaign and getting this program to ground level within support of our health department. Thank you.
See the concept of community medicine and then the concept of community mental health. This came for the first time when Imam Ghazali gave the concept of different dimensions of health, physical, mental, social and spiritual. And when we look at different communities, but I will restrict my discussion very briefly to the Kashmir community. In different communities, the concept of community mental health was governed by the dominating forces that time. And when I say dominating forces, I mean the religion. If you look at Hinduism, the Mansik Swas, the concept is very old and it is well documented in our Vedic treasure of knowledge. When we look at our culture, it is the dominant force is Islam. In Islamic culture, the Ghazalian concept was dominant. But a solid shape was given to it after Second World War when World Health Organization came into being and the concept of mental health as a strong dimension of health was adopted. And the community awakening started. And as all of us know, the first person to give the concept of community mental health is the mother of the child, who would always, when vigilant and see the child in her lap, she would notice that her behavior is wrong. And in Kashmir they say she was a type of a mutu, or she noticed some changes in his behavior, and that was brought to the first line healthcare provider, whether he was an imam or a school teacher. And this sort of thing existed in the community.
But it has changed over the years because of the situations here. So the demand for psychiatrists and psychosocial support has gone enormously, and that's why we need to decentralize it and need to bring it to the communities services. And for that we have seen that MSF came quite early in 1999. They started with Ganderbal first mental health program. Then people start realizing that mental health need to be brought to the community and it has to come off the institution. And the institutionalization, I believe, started from that time only. And today, because of the district mental health program and national mental health program, it has come and came to the grassroots level. Now we have the comprehensive primary health care. Previously, primary health care used to be primarily related to the common ailments, but now they have included the mental health as a basic requirement. So, starting from a specific institution for mental health, it has been deinstitutionalized under these programs and is at now, I believe, to some degree accessible at a very nearby place with some degree of expertise available for the people having mental illnesses. So I believe it will go further, but because of staff paucity and those expertise, the number of psychiatrists is increasing, I believe, but the mental health problem is quite enormous and huge. We believe that it has been deinstitutionalized and hopefully the stigma which was associated with mental health is erased now. It doesn't happen that people are taking mental health as a problem, but it is a norm as any other disease.
Community or public health specialist, I still have yet to feel that community mental health programs have got any clue. Maybe we are doing small things, just like we talked about MSF and other organizations are working. But I think there is a lot at the ground level which is yet to be explored. It's a lot which needs to be done. It's a drop in the ocean what we are doing right now. And I think challenges have been there and they are still there. I may not agree fully with Dr. Salim sir here. Probably one of the biggest challenges which I have experienced in the field was the acceptance of mental health problems. I have seen a number of times parents, attendants, relatives deny it. Because accepting that a relative or a family member has a mental health issue, which is highly stigmatized, is very difficult as of now. It's often hidden under a possession syndrome. So, I've seen so often that people would not go to a counselor or a psychologist or a psychiatrist. They would go to a faith healer because it would be easy to hide this problem. There is some possession, jinn, the Stuttgart, this and that, and not a mental health problem which is significantly and severely stigmatized as of now in Kashmir.
It is a privilege to meet with all classmates. We had roll number 72 and 73, Dr. Mushtaq and myself. So we used to be side by side, right from first MBBS till the end. And we met after 45 years again, and I found myself lost in a different world when I was facing a psychiatrist. I used to face some patients outside who had a psychiatric problem, but we least used to bother about it and hand over it to a psychiatrist and wash our hands. But when it came to practical, Dr. Margoob, he pulled me, he said, no, you come. I had an opportunity to go around with him. I feel I am a student, you see. What I had never seen, I have seen with him. He is a person which is a lighting candle, you see. The light goes all around. It's not a bulb, it's a candle, you see. 30, 40 years back, we used to call Pagal, Chor. These words are odd now. If you call anybody Pagal, he feels that you have abused him. If you call somebody Chor, they are Kashmiri words, you see. If people feel he is himself something, thinks himself to hide this, that. But Dr. Margoob, you see, as I knew from the people around, I feel myself proud to be a part of his team, and every time I work here and at his support.
The past is about institutionalization of these patients, of the mental health patients. We had patients always, as you said, about the central jail, it was asylum. So the past people were put in the asylums and they were not allowed to move around, and every care was institutionalized. Over time, what we have seen is that it was a model which was a failure. Then the community model came in, and in the community we have seen that general hospital units, people working in the communities delivering the care at their doorsteps. This model became a main thrust. However, the problem with the community model was that we have now a mini asylums. Everybody is working in one space. Suppose I have a patient, I went to OD and we went for a psychological first aid, or we went for the basic counseling post this OD award. So after that, what we are going to do? We are not doing anything after that. We do the basics and we will follow them up. So we should not actually institutionalized care. We have come forward to that. Even in your own hospital, it's not institutionalized care. We still follow that because we have our own legacy. All the medical colleges, all the district hospitals, they don't follow that care. But coming to the community, learning from the past and going to the community. But we don't have created those many asylums there, where only those models are based on just one place. So that's a point that we should learn, not creating any mini asylums in the community.
I have done my psychology in 1969, 67, 69, and MPhil for Aligarh University. I must tell you, at that time, the psychology was nowhere existing in Jammu and Kashmir. I can record it, but I never thought about it. The reason is that I came across you said our peer, had certain problems in the family, my mother used to go and I used to accompany her, I could see her. And I had been fortunate to have Dr. Madhosh Sahab. He was another professor in the University of Psychology where from he had done. So the point is that I did it, nobody had done. When I came back, first of all, there was a lot of problem in Aligarh University to get the admission, because admission in post-graduation used to be based on the what subject you have in the graduation. I had education and I had, that's all. And there I have been, somehow very interested about the child psychology. So I did a great, efforts. I got psychology department established in 1970 in Maulana Azad College. Therefrom you get a lot of students, all convent students used to come because there is a memory test. There is a, IQ test because of that. So the point is that then somehow my destiny was I taught there 16 years and in the university also, child psychology, home science department.
It's my honor and privilege to host this session, and we have a panel discussion here, and I have been given 3 names or 3 organizations here. They will speak for 10 minutes, the program will be for 45 minutes.
Community interventions to deal with them. But what is the real burden of the mental illness in Kashmir region? I would say in the Kashmir region of the J&K. We have 3 major studies. The first one was in 2006 by Professor Margoob. It was a whole supplement of J.K. practitioners, which was indexed, PubMed indexed journal at that time. Sir was acting as a chief editor of the journal that time. All the studies were done by Sir and the students that time, Majid Sir, Lauds Sir, Ashok Sir, and then Dr. Akash Sir. That was the first major study which actually pointed towards the prevalence of the mental health illness in Kashmir. Then after a decade, it was a study by MSF in collaboration with IMHANS. Then we have this recent study by Professor Arshid, Dr. Mansoor and me, including again in 2014. So we have 3 major studies. All of them point towards a very high burden of common mental health disorders in Kashmir. So strengthening helpline and telemental helpline, we are getting good response 14416, and obviously we need better infrastructure. And we need a continuous monitoring and data collection.
An NGO or any institution will not be there in any community for lifelong. There has to be an exit strategy. The exit strategy is to strengthen the local institution. And that local institution can be Baitul Mals, Masjid communities, Awqaf communities, or even a group, youth group, like as I said, a Poshover group that we had created. And every program should carry a psychosocial lens. Very important. See, we NGOs have the tendency to measure the success of any program through numbers. For example, I will say my program is successful because out of 100, 90 students made it sure that they passed the 10th and 12th exams. We made it sure that the graduation, the success rate of graduation or post-graduation program is 80%. Or I will say the business units that we have provided, out of 100, 80 are successful business. But we have to ask ourselves, did it reduce stress? Did it provide dignity? Did it help in confidence building? While we focus on the material gains, we should never ever forget the emotional and the social part of it. And finally, we need to measure impact carefully. Definitely, key performance indicators like ownership, behavior change, and resilience will show us if communities are truly transforming. And the main message here is inclusive well-being cannot be delivered from outside. It has to be co-created with the society. Thank you.
आज का प्रोग्राम जस्ट एक प्रोग्राम अगर है तो कोई मतलब ही नहीं है इसका। अगर ये एक प्रोसेस है जो होता रहा है कि कम्युनिटी में 90% जो हमारे लोग हैं, 90% लोग हैं हमारे कम्युनिटी में, उनको आज भी नफ्सियाती माहिरीन या नफ्सियाती तौर पे जो इलाज मिलना चाहिए था नहीं मिल रहा है। यह तहकीक है। और उस सिलसिले में जब आप देखेंगे तो सब लोगों को जो इसमें जुड़ सकते हैं, आप समझ लीजिए जो ग्रास रूट लेवल पे एक सिलसिला है वहाँ कुछ होता है। और जो टॉप मोस्ट, जैसे आपने देखा कि जो इंस्टीट्यूशंस हमारे हैं جہاں ٹریننگ بھی ملتی ہے, ٹریٹمنٹ بھی ملتا ہے, وہ کنیکٹ گراس روٹ لیول تک کیسے پریکٹیکلی, یہ ایک عملی ایک سلسلہ آج کا. لیکن آپ نے دیکھے جو کریڈیبل این جی اوز بھی ہیں, آپ نے دیکھا جو باقی لوگ اس میں شامل ہو سکتے ہیں یا اپنے اپنے طریقے سے ہیں, تو ان کو سب کو جمع کر کے آپ سمجھ لیجئے ایک چھوٹا سا کنواں ہے, لیکن اگر یہ ایک ندی بن سکتی ہے اور اس ندی سے سب جو سلسلہ ہے جو سیراب کرنے کی ضرورت ہے, مینٹل ہیلتھ کے, مینٹل ڈیزیز کے بارے میں بات نہیں کر رہا ہوں, مینٹل ہیلتھ پریونٹیو زیادہ ہونا چاہیے, پروموٹیو ہونا چاہیے. تو اس میں آپ نے دیکھا کہ جو بھی ڈسکشنز وغیرہ چل رہے ہیں, پریزنٹیشنز چل رہے ہیں, اس میں ہم اس پہ زیادہ ایک فوکس ڈالتے ہوئے ساتھ ساتھ یہ بھی کہ اگر یہ ہے کہ نفسیاتی تکالیف جو ہیں, آپ اگر مان لیں کہ 10, 12, 15% بھی ہیں, لیکن باقی جو لوگ ہیں ان کو وہاں نہ ہونے دیا جائے. ثواب ایک انیشیٹو رہا ہے, اس لیے کبھی اس کو این جی او کے, کیونکہ اتنے این جی اوز ہیں اچھا کام کرتے ہیں, ان کو سپورٹ کر لیجئے. میرے پاس یہ مشورے یا ان کو اس سلسلے میں کچھ گائیڈنس کی ضرورت رہی ہے پچھلے 30 سالوں, نامساعد حالات کے 35 سالوں یا اس سے پہلے, وہ ایک سلسلہ. لیکن آج کا جو آپ یہ کہہ رہے ہیں کہ اگر آپ کو نفسیاتی اس مسئلے پہ یہ نظر ہے, یہی حال ہر کسی ہم میں سے بحثتی انسان ہے کہ وہ اگنور ہوتے ہیں, ان کے ہیومن رائٹس وائلیٹ ہوتے ہیں, ان کی جو لیکن ایک بات میں کلیئر کرنا چاہوں گا کہ ہم صرف ڈیزیز پہ بات نہیں کر رہے ہیں. یہاں آپ نے دیکھے ایکسپرٹ صرف ڈیزیز یا مینٹل ہیلتھ ریلیٹڈ جو ٹریٹمنٹس ہیں وہی ماہرین نہیں تھے, زندگی کے باقی اور جو میڈیسن سے بھی باقی کمیونٹی میڈیسن کے ہیڈز 3 تھے آپ کو وہاں, جنہوں نے اپنا تجربہ پچھلے 50 سال کا تجربہ, سینئر اور کرنٹ جو ہیں ہیڈ آف ڈپارٹمنٹس. تو اس لیے جب آپ وہ دیکھیں گے اس سے تبدیلی آئے گی ایکشن سے. جو ہم ڈسکس کر رہے ہیں مطلب سرمنز دینے سے, لیکچرز دینے سے, پریزنٹیشن سے, کانفرنس سے کچھ نہیں, جو میں ہمیشہ کہتا رہا ہوں کچھ نہیں بدلتا ہے. اگر بدلنا ہے تو وہ کمیونٹی میں ایکشن سے بدلے گا, اور اس کی ایک سنگ میل بھی ثابت ہو سکتی ہے اگر لوگ اس کے ساتھ جڑ جائیں. تب تک کچھ نہیں بننے والا ہے. اگر سب لوگ جڑ جائیں کہ نفسیاتی مسئلے ایسے ہیں, وہ بھی بالخصوص کشمیر جیسی جگہ میں, آپ نے دیکھا, آپ نے سنا کہ یہاں کا ماڈل باہر گیا, کینیڈا میں آج بھی اس کو لیڈ کرتے ہیں وہاں کے کمیونٹی جو میڈیسن کمیونٹی سائیکیٹری کے جو سائیکوسس کے تھے ماہر, اتنی دیر سے رہے ہیں, ماہر ہیں, وہ آپ کو کہتے ہیں کہ ہم نے یہاں جو آبزرویشن کی وہاں لی. تو یہ سلسلے سب لوگ کر سکتے ہیں, سب آرگنائزیشنز کر سکتی ہیں, ٹھیک ہے نا. اس لیے مجھے پوری امید ہے کہ اس پہ عمل ہوگا. نیت نیک ہوتی ہے ہر کسی کی, چاہے انفرادی طور ہو, اجتماعی طور پہ, لیکن ہاتھ ملانے کا جو تقاضا ہے اس کے لیے اب ہونا چاہیے. ابھی اور مزید ہم انتظار نہیں کر سکتے ہیں. جزاک اللہ.